Hello, I'm Bruno Ciubitazzi. I'm an assistant professor of pediatrics at Baylor College of Medicine. I'm also the director of neurogastroenterology and motility at Texas Children's Hospital. We're joined here today by Dr. Doug Fishman, who is an associate professor at Baylor College of Medicine and director of the endoscopy unit at Texas Children's Hospital. Dr. Fishman is the senior author on the manuscript we will be discussing today.
Thank you. And I'd especially like to thank Gastrointestinal Endoscopy for giving us the opportunity to discuss our work entitled Quality Indicators for Pediatric Colonoscopy, Results from a Multi-Center Consortium.
Dr. Fishman, why did you do your study?
Well, we know there are clear differences in the performance of pediatric and adult colonoscopy. Beginning with indications, we evaluate more patients for inflammatory bowel disease and less often for cancer screening. In pediatric patients, there are different anesthesia risks, and adequate bowel cleansing can be challenging in the younger patient. Also in pediatrics, ileal intubation is the standard compared to cecal intubation for adult patients undergoing colonoscopy.
What is known about quality indicators in colonoscopy at this time?
Well, in adult patients, several metrics for colonoscopy have been established. They are now based largely on recommendations from task forces and GI societies such as the ASGE, AGA, and ACG. In 2010, a multi-society panel created the Physician Performance Measurement Set to further standardize quality measurements. Taken from our adult GI colleagues, colonoscopy competency is a technical skill that is frequently defined as the ability to intubate the cecum. 95% is the standard used to maximize adenoma detection rates in adults for screening, and more than 90% is expected in all cases.
How did you conduct the study?
Well, we used the PEDS Cori registry, data from 13 pediatric sites from the year 2000 to 2011, and we used this to evaluate over 21,000 pediatric colonoscopies. We focused on time of procedure, ASA classification, bowel preparation quality. We also collected endoscopist characteristics such as sex, colonoscopy volume, and time since fellowship.
That sounds very comprehensive. What did you find?
Well, the most common indications for pediatric colonoscopy in this cohort were abdominal pain, hematochezia, diarrhea, and inflammatory bowel disease. Abdominal pain was the sole indication in less than 15% of cases, and approximately half of the procedures were performed with general anesthesia. The ASA classification was documented in over 80% of reports, and colonoscopy time was generally around 30 minutes, slightly longer at 32 minutes when ileal intubation was performed.
That's interesting. Did you take a look at trainee data?
We did, and we did identify that the presence of a trainee was shown to increase procedure time by only 7 minutes, 37 versus 30 minutes, but trainee participation did not influence TI intubation rates.
The ileal intubation rate data is very interesting. Can you tell us a little bit more about that with your data in terms of a metric?
Well, we did look at number of colonoscopies performed by an individual endoscopist, and for those with at least 200 colonoscopies performed, the overall ileal intubation rates were 84%, and those with planned ileal intubation. We also found that children under 6 had lower rates of TI intubation, 73% versus 48%, and the poorer the prep, the less often the endoscopist was able to intubate. Candidate quality metrics. Pre-procedure, indications, risk assessment, ASA classification. Interprocedure, photo documentation, use of reversal sedation medications, procedure duration, cecal and ileal intubation rates, bowel preparation quality, estimated blood loss, extent and completeness of exam. Post-procedure, complications, adverse events, and unplanned interventions.
What are the future implications of your study?
Well, our hope is that this study will serve as the foundation for determining quality metrics in pediatric colonoscopy. Improving procedure times, ileal intubation rates, and bowel prep quality are likely to improve our ability to provide a safe and efficient colonoscopy to our pediatric patients.
Thank you, Dr. Fishman, for discussing your manuscript today.
Thank you.